In this lecture, we will discuss left bundle branch block, including its pathophysiology, EKG features, potential causes, and clinical significance. If you recall, the normal electrical conduction system of the heart starts with the SA node or the sinus node in the upper right atrium. So just to review, here's our sinus node. This is our right atrium here. This would be our left atrium, our right ventricle, and left ventricle. Okay, so we have our sinus node up here in our right atrium. Then we have our internodal pathways, or Bachmann bundle that comes to the left side. Here's our AV node. Okay, from our AV node we have our His bundle. Okay, and then it splits off into a right bundle branch, which is this one here, and then we have a left bundle branch. Okay, the left bundle branch then subdivides into a left anterior fascicle and as well as a left posterior fascicle. Okay, and then both these fascicles and the right bundle branch end in the Purkinje fibers that innervate the myocardial cells. Now our focus in this lecture is going to be on the left bundle branch block, okay? Or when the left bundle branch is blocked, or we can have the left anterior and left posterior fascicles blocked together, okay? So that's one thing. Note these regions here, okay? So when we talk about left bundle branch block, it could be the initial portion blocked right there at the head, or it could be that we have this left anterior fascicle block as well as the left posterior fascicle blocked. Okay, in either way, we have conduction that's blocked to both fascicles. Okay, now if the electrical impulses generated by the pacemakers in the atria or the AV nodes suddenly hit an obstacle in their normal conduction pathway, they will not be able to proceed to the cells downstream from the block. Instead, the impulses will travel by direct cell-to-cell transmission. And this is a slow, chaotic means of innervating the myocardium. It results in wide, bizarre QRS complexes that are often seen in bundle branch blocks. Remember, when we talk about premature ventricular contractions or PVCs, this results in a wide QRS complex as well. The difference here is that the PVCs are aberrantly conducted right from their start, right from the origin in the left and one of the ventricles. That's when we see the problems occurring. However, with the bundle branch block, you have normal conduction right from the start of the impulse until it hits that block. Okay, it is the initial component that gives bundle branch blocks two main appearances with minor variations. Okay, and that's where we get the right and left bundle branch block patterns. Here, our focus is the left bundle branch block pattern. Okay. So let's take a look at what we have going on here in left bundle branch block and the EKG features. So we said it can be caused by a block of the left bundle branch or of both the left anterior and left posterior fascicles. And this block causes the electrical potential to travel down the right bundle first because it's unobstructed, and then the ventricular depolarization will head from right to left by direct cell-to-cell transmission. Okay, so again, what we have going on here, just to clear this up, we have conduction normally from our sinus node. It comes to our AV node, and we can come down this right side, our right bundle branch, okay, and start depolarizing the right side of the heart. However, things are obstructed on the left side, and because of that, the right ventricle depolarizes first, and then things will head from right to left. Okay, so in our right bundle branch, we had the vector going the other way. And now in this case, the late vector is heading from right to left, and that's that green vector we see here. Okay, going from the right side to the left side of the heart. Okay, and that's a slow cell-to-cell depolarization, a slower process as it heads in that direction. Okay, now the left ventricle is so large that the transmission is delayed, and hence wide QRS complexes greater than or equal to 120 milliseconds often appear on the EKG. The slow transmission gives rise to broad monomorphic complexes commonly seen in left bundle branch block. In addition, because the unopposed vector is proceeding from right to left, these complexes are negative in the right precordial leads and positive in the left lateral heart leads. Okay, so again, leads V1 and V2 sitting over the right ventricle, our most anterior portion of the heart, are this vector. Notice that the green vector is heading away from those leads. Okay, so we'll see a negative complex. Right, here's V1 and V2, and we see this mostly negative complex, that S wave there. And then in our lateral leads, right, we have V5, V6, and then we also have 1 in AVL. All right, the left lateral leads of the left ventricle. Notice that vector is heading towards it, so we'll see these positive upright complexes. Okay, notice that it's all positive in that area. Okay, so as it's heading away or towards those leads, we see those. And again, remember that we have wide complexes here. Okay, from the beginning to the end of our QRS complexes are wide because of that slow cell-to-cell depolarization that's moving from right to left. Now note that the right precordial leads V1 and V2 may also have a small R wave due to the initial vector produced by innervation through the right bundle branch. Okay, remember that right bundle branch is still normal. Okay, and because of that, we may actually have this right bundle branch heading and depolarizing this side, where in such cases we can see this initial small R wave. Okay, remember, here's our right precordial leads, and that initial vector of the right ventricle being depolarized may be seen as a small R wave in lead V1 or V2. Now, another normal finding with bundle branch blocks is discordance. In other words, the ST segment and T wave are directed in the opposite direction to the main QRS vector. Okay, and let's see that here. Let's just erase what we have going on. So again, notice that we have mostly negative complex here of our QRS, and then if we draw our baseline, we can see that our ST segment is elevated and our T wave is upright. Okay, this is our T wave, so that's going up. And when they're going in the opposite direction, we call that discordance. And we see the same thing in the lateral leads. Okay, here's a mostly positive QRS complex and negative, right? If we draw our baseline, ST depression and T wave inversion. Okay, so going in the opposite direction here. Now, if the ST segment and the T wave went in the same direction as the main QRS vector, we call this concordance and may actually suggest underlying pathology such as myocardial ischemia. Now, some other features that may be seen in left bundle branch block include left axis deviation. Okay, remember left axis this is normal axis, usually from negative 30 to about positive 110 or 105 degrees. So leftward axis would be in this region. Notice that our vector's heading in that direction, so that's one reason, one thing that could support the diagnosis. Poor R wave progression in the precordial leads, V1 through V6, as well as an increase in the R wave peak time in leads V5 and V6. Okay, usually that's greater than or equal to 45 milliseconds. Usually the intrinsicoid deflection, right, is less than 45 milliseconds in V5 or V6. Okay, so that's the main EKG criteria for left bundle branch block. I hope they make sense. All right, now you should note that if all these criteria are met except for prolongation of the QRS interval, then this is considered an incomplete left bundle branch block. In other words, it's considered complete left bundle branch block only when we have all criteria met, including the prolonged QRS interval. Okay, so just like when we talked about right bundle branch block, having that QRS interval prolonged makes it complete. If it's normal or less than 120 milliseconds, it's considered incomplete. All right. Now let's just end by looking at some of the causes and the clinical significance of left bundle branch block. So some causes include idiopathic left bundle branch fibrosis or degeneration, aortic stenosis, hypertension, ischemic heart disease as a cause, heart failure, left ventricular hypertrophy. As the left ventricle gets bigger, it could stretch these fascicles in the left bundle branch. Valvular heart disease can cause it, cardiomyopathy, anterior MI is one of the causes, myocarditis, digoxin toxicity, as well as hyperkalemia. Now, clinically speaking, left bundle branch block is always considered pathological, which is different from what we saw with right bundle branch block. In fact, these patients often have adverse cardiovascular outcomes secondary to impaired left ventricular function. And if it's acquired, these patients are at a greater risk of heart failure, coronary artery disease, and right ventricular hypertrophy. Now, while right bundle branch block did not affect the diagnosis of ischemia or infarction, that is not the case with left bundle branch block. Various criteria have been proposed to diagnose myocardial ischemia and infarction in such settings, okay, such as the Scarbosa criteria, although we're not going to get into that here. You can look that up if you're interested. And lastly, left bundle branch block does affect the diagnosis of left ventricular hypertrophy. All right, let's briefly review what we discussed before we end. So left bundle branch block, okay, is an anatomical or functional dysfunction in the left bundle branch or both the left anterior and left posterior fascicles. Okay, the block causes the impulse to travel down the unobstructed right bundle branch first, and then we have that slow cell-to-cell depolarization as we head from right side to the left side of the heart, okay, that later vector. And because of this, we get those wide QRS complexes because of the slow cell-to-cell depolarization, the broad S waves in the right precordial leads, and the broad R waves in the lateral leads, okay. Now just to show on our 12-lead EKG, here's lead 1, here's lead AVL, V5 and V6, okay, and in these cases we're going to see those broad R waves, the broad monophasic R waves, which are here, okay. Notice them all in these cases, and again they're wide. And one thing is that we won't see a Q wave except possibly in AVLs, okay, so no Q wave that's present in these leads. You may see one in AVL, but in the other ones you don't want to see it. That would be that's one thing, one of the diagnostic criteria, okay, no Q wave except possibly AVL. In terms of the right precordial leads, V1 and V2, okay, in these we're going to see those broad S waves where we could see, here's our broad S waves, okay, notice we see that here as well, okay, and these broad S waves are because the vector is heading away from right to left, away from V1 and V2, okay. You can sometimes see notching in the S wave, that's possible, and sometimes they consider it a W type. Remember, we called the M type or M shaped in the right bundle branch block, okay. Now remember, just like the right bundle branch block, ST and T wave discordance going away from the main QRS vector is something that's normal in bundle branch blocks. If you see concordance in which they're going in the same direction, that may suggest underlying ischemia or some other pathology. Now other features, we mentioned left axis deviation, poor R wave progression in the precordial leads, as well as an increased R wave peak time or intrinsicoid deflection in leads V5 or V6. We mentioned a number of causes here and the clinical significance. Remember, this is always pathological, okay, and these patients do have adverse cardiovascular outcomes versus those with right bundle branch block, okay. So remember, with right bundle branch block, if those patients are asymptomatic, they tend to be okay. But in such cases like this, if these patients develop left bundle branch block, they tend to have a worse prognosis. They're at a greater risk of heart failure, coronary artery disease, as well as right ventricular hypertrophy. And remember, in left bundle branch block, the diagnosis of ischemia and MI, as well as left ventricular hypertrophy, is affected from it. Well, that's the end of this lecture. We discussed left bundle branch block, including its pathophysiology, EKG features, potential causes, and clinical significance. I hope you learned something.